Thank you, chairpersons, for kind introduction. And thank you, Dr. Radhakrishnan, for giving me this opportunity. My topic of discussion today is carbon dioxide footprint in perioperative medicine. I do not have any conflict of interest. What is carbon dioxide footprint? The carbon footprint is total greenhouse gas emission by an individual, event, organization, or a product. Methane, nitrous oxide, and fluorinated gases, they constitute a significant amount of total carbon dioxide footprint. Now, it has been seen that in modern perioperative health services, they are responsible for generating almost 650 to 1200 kgs of medical waste daily. And this approximately is equivalent to 3 million kgs of annual greenhouse gas emission per hospital. Methane, which is released, is 25% more potent than carbon dioxide. Nitrous oxide is 300 times more potent than carbon dioxide. And you'll be surprised to know that gases released from refrigerator are 1,000 times more potent than carbon dioxide. Perioperative medicine can result into pollution of air, soil, and water because of release of sulfur, nitrogens, anesthetic gases, toxic materials, particulate matter, and persistent organic material. It has been estimated that in the United States, 8% of the nation's greenhouse gas emission is because of perioperative medicine. And in UK, NS is responsible for 25% of total public sector emissions. In India and China, the healthcare accounts for approximately 5% of national carbon dioxide footprint. Although at the outset it may seem to be a very less percentage, but if you calculate population wise, this is a significant impact. Now, what are the methods for estimation of carbon footprint? The carbon footprint is estimated by global warming potential, that is the rising temperature by greenhouse gas is calculated mathematically. And this is expressed in terms of carbon dioxide equivalents. The quantitative expression of greenhouse gas emission is estimated by life cycle assessment of a product. What is done? The estimation and addition of entire amount of greenhouse gas emitted in complete life cycle of a particular matter, right from its manufacturing to its consumption and disposal, is calculated, and this is known as cradle to grave analysis. What are various accounting resources? They are Greenhouse Gas Protocol of World Resource Institute, International Organization for Standardization, and public available 2050 of British Standard Institution. A bottom-up or top-down method is used for analysis. Either of these can be used. However, practically speaking, a combination of both these analysis is used. This is known as a hybrid method, which is a combination of economic input-output and life cycle assessment. This technique is not only robust, accurate, but flexible and reliable. Now, this analysis is carried out in 3 steps. Step 1 is selection of greenhouse gas, that is the type of activity for which calculation of footprint is required. Then is setting the boundary, that is to establish exact fraction of an organization. And then data is collected by these institutes. And then greenhouse gas emissions are calculated using a complex algebraic conversions, which will provide the carbon dioxide equivalent. The carbon dioxide footprint starts occurring the moment a particular patient leaves his or her home to reach the hospital till the period he reaches back home after discharge from hospital. And the major sources of carbon footprint are production and use of disposables, including single-use surgical devices. So this I have highlighted in red because anesthetic gases and energy used for HVAC, they are the one of the major sources. And all the OR waste, which is designated as clinical waste, this results in requirement of disposal by incineration, contributing to the carbon footprint to a large extent. Now, what are the anesthesia-related reasons for carbon footprint? They are volatile agents used, then intravenous anesthetic agents, then medical waste, HVAC system, anesthesia-related and surgery-related material supply chain, then civic solid waste, hazardous waste, liquid effluents, sharps, black box waste, reusable linens, then transport of waste to the designated area for incineration or disposal, and miscellaneous are plastics, glasses, bottles, aluminum wrapping for sutures, gloves, basins, disposable gowns, drapes, and sweats. The impact of surgery on global climate was beautifully analyzed by McNeil. What they did, the surgical suits of 3 academic institutes were studied over 1 year period, and it was seen that approximately at John Radcliffe Hospital, 51 million kg of carbon dioxide equivalent were released, and in Minnesota, 41 million, and in the Vancouver General Hospital, around 32 million. And it was interpreted that operating theaters are an appreciable source of greenhouse gas emissions. And when it was analyzed, then desflurane use was the main source of carbon footprint at Vancouver General Hospital, followed by Minnesota, and in John Radcliffe, they did not use desflurane. So you can see that if desflurane, isoflurane, and sevoflurane are compared, desflurane is associated with highest resultant carbon footprint. And this was the energy used by HVAC, lighting, plug loads, and so total was around 53 million at Vancouver, and Minnesota 15, and 43 at John Radcliffe Hospital. And it was seen that the waste type, processing, and final destination, when they are reached, it has to travel a large distance. What about inhalational anesthetic agents? Inhalational anesthetic agents, they are powerful greenhouse gas emitters. They remain in atmosphere for nearly 1 to 15 years, and they are significant heat trapping gases. Nitrous oxide has a lifetime of 114 years with a heat trapping potential 310 times as of carbon dioxide. Sevoflurane has 130 times heat trapping potential of carbon dioxide on a 100-year time scale. And this again I have highlighted in red. Desflurane is 2,500 times more potent. Therefore, sevoflurane is preferable as compared to desflurane, and TIVA should be preferred over inhalation agents wherever possible. Although most of the developed countries are now not using nitrous oxide, but in India it is still widely used. And this we will talk later on about the life cycle assessment of LMAs. But the disposable LMAs, they are associated with a significant amount of carbon footprint as compared to reusable LMAs. The life cycle assessment of greenhouse gas emission of anesthetic gases was calculated in a study, and it was found that desflurane accounts for largest life cycle greenhouse gas impact among the anesthetic drugs, which is 15 times more than that of isoflurane and 20 times that of isoflurane on a per mag hour basis when administered in oxygen air mixture. And if nitrous oxide is added, then it reaches a quite high value. So again, we can see that the use of inhalational anesthetic gases is associated with significant amount of carbon footprint as compared to propofol. The impact of gases on global climate was assessed by Anderson et al. Again, and they find that the radiative forces, because of anesthetic gases, they were depleting ozone layer in a significant manner. This is a very interesting study. In United States, the life cycle assessment of hysterectomy was assessed. Hysterectomy was chosen because it is one of the most common surgeries done worldwide. So in this study, hybrid life cycle assessment was used to quantify environmental emissions from 4 different types of surgical approaches, that is abdominal, vaginal, laparoscopic, and robotic hysterectomies. And this was calculated right from manufacturing of materials used for hysterectomy use, and then disposable, and ultimate then incineration and landfills and the methods for disposal. And it was seen that robotic surgery was associated with the highest amount of carbon footprint as compared to the other approaches. It was followed by laparoscopic and then abdominal and vaginal. Why? Because robotics, they are quite lengthy procedures and involving a lot of disposables as well. Therefore, the choice of volatile anesthetic does matter when we consider carbon footprint. And because of this awareness, it was seen that in the hospitals, the use of desflurane is constantly decreasing. And this is just a cartoon showing that 1 hour of surgery using sevoflurane is equivalent to driving 5 to 10 kilometers, whereas nitrous oxide is driving 106 kilometers. And if desflurane is used, this again highlighted in red, this is equivalent to driving 200 to 400 kilometers. The comparative life cycle assessment of disposable and reusable laryngeal mask airways was calculated by Eckelman et al. And they found that the reusable LMAs were found to have a more favorable environmental profile than the disposable LMAs as used at that hospital. The most important sources of impact for the disposable LMAs were production of polymers, packaging, and waste management, whereas for the usable LMAs, washing and sterilization dominated the most important categories. And we can see this carbon footprint impact, that this is for the reusable and this for the disposable. For this disposable, it is quite high as compared to reusable. What are the adverse effects of carbon footprint? Carbon footprint can result into climate change, can lead on to global increase in temperature, melting of glacier, rise in water level, ozone layer depletion, decreased amount of rainfall, and increased incidence of acid rain. And moreover, it has carcinogenic potential. So what should we do to reduce perioperative carbon footprint? McGinn et al., they audited operating room recycling, and they found that when the things were recycled, this did not increase any incidence of infection. So, meaning by that, the things should be reused wherever possible. Again, a multi-center quality improvement report was submitted by the authors in 2012, and the breakdown of joint replacement waste by weight was calculated, and it was seen that this amount of things was recyclable, and then purple they were potentially recyclable, and this constituted the clinical waste. So the authors suggested that one should prioritize the environmental health, substitute harmful chemicals with safer alternatives, one should reduce and safely dispose of waste, energy should be used efficiently, and one should switch to renewable energy, water consumption should be reduced, one should try to improve travel strategies, and sustainable food should be purchased, pharmaceuticals should be safely disposed of, and a greener building design should be adopted for construction, and the hospitals they should purchase more sustainable products. Now, this is again a very recent interesting study in which Foreigner et al. They estimated carbon footprint when the patients they are reaching a outreach clinic as compared to tertiary care center, and it was seen that lot of patients had to travel a long distance to reach the tertiary care hospital. So therefore, if outreach clinics they are made in the peripheries or smaller areas, then the carbon footprint can be reduced to a larger extent because of traveling. The operating room waste in neurosurgical operation theaters, it was calculated. As we know that mostly disposable things are used, and they are more used in neurosurgery. So it was estimated that lot of things they were lying unused, and this contributes to a significant amount of carbon footprint. So among 58 procedures, the average cost of unused supplies was approximately $653, or 13% of the total surgical supply cost. So this figure shows that the total surgical supplies average cost was $8,377, and unused supplies, that is once they are opened and they are not used, they constituted the wastage of $653. Then a survey was carried out just to know about the attitude of anesthesiologists and their knowledge about the um, waste supply and how to prevent carbon footprint. So it was seen that majority of the respondents they reported that they had insufficient information on how to recycle intraoperatively, and a total of 12.6% of the respondents indicated that the presence of a mandate from hospital leadership was lacking, and there was also lack of sustainability programs. So the important conclusion drawn from this survey was that there's a lack of hospital-wide organization of sustainability programs, and a belief among the survey responders that they lack inadequate information on recycling and sustainability. So therefore, to minimize carbon footprint, one must try to use minimum materials in the operating room, whatever is needed. There should be emphasis on reusing linens and towels. The clinical waste which is there, it should be recycled and regulated. Single-use devices should be reprocessed wherever possible, and hospital building should maximize the use of renewable energy sources available on existing grid system. Harmful medications should be substituted with a safer alternatives. Pharmaceuticals, they should be safely managed and disposed of, and one should try to purchase safer and more sustainable products. Water consumption should be reduced, avoid using bottled water, and avoid any unnecessary or harmful intermission, and very important, avoid misallocation of patients. Unnecessary ITU admissions should be reduced. Use telemedication wherever appropriate. And there should be provision for ambulatory healthcare to reduce unnecessary transport. The WHO recommends that the hospitals, they should be climate friendly. They should increase hospital energy efficiency. There should be green building design and renewable on-site energy generation sources. And there should be alternative fuel for the hospital vehicles. The hospital staff should be encouraged by walking or cycling, and the cars, they can be pooled, and even staff should be encouraged to use public transport. For the staff and patients, there should be provision for sustainably grown local food. Then reduce, reuse, and recycle inventory. What's the role of anesthesiologist? Anesthesiologist can contribute a lot for reduction in carbon footprint. So one must try to reduce gaseous waste by using low fresh gas flows, avoid high impact anesthetic inhalational agents such as desflurane nitrous oxide. It is worthwhile investing in waste anesthetic gas trapping or VAG destruction technology for the anesthesia machines. IVRA, IV regional techniques should be encouraged, and one should use pre-filled syringes so that the intravenous pharmaceutical waste can be reduced, and appropriate size vials which are single used should be there for required dosages. So these can reduce the problem of disposing of unused medication to a large extent. So one must try to reduce anesthesia equipment waste by opening minimum required equipment, which is very important, and prefer procurement of reusable and reprocess of equipment over disposables. And stock inventory should be adjusted to minimum required levels by reduction of expired items. And one must try to segregate waste type carefully, such as pharmaceutical, solid, and biohazards. It's particularly important to avoid putting the waste into a single bin, which makes these recycling programs extremely difficult. This is especially true for clean plastics, paper, and cardboards. Instead of using disposables, one should seriously consider using reusable linen. Another thing, electronics constitute a significant component of operating room. One must avoid the use of electronics which have no proven benefit in a particular case, and one must use a qualified electronics cycling vendor. It should be identified, which can help for disposable of old equipment while negotiating for upgradation of equipments which are already existing. And the distributors and suppliers, they should also be impressed upon to take back old equipment for refurbishment, reuse, or even possible donation. Anesthesiologists, they should take a leadership role in establishing a sustainability committee at their workplaces by prevention of pollution, by perioperative healthcare, This should be made an important mission, and they should be proactive in educating staff members regarding cost benefit of various environmental projects. So these uh, things can lead on to remarkable reduction in greenhouse gas emissions and environmental pollution. This will also result in a substantial financial cost cuttings for savings for hospitals. One must re-examine and reassess the impact of clinical practice towards development of a safer environment. Inhaled anesthetic gases should be reduced. Intravenous used medication and old discarded anesthesia equipment, it should be reused wherever possible. So again, not to under emphasize that appropriate segregation of solid waste should be there and use reusable linen. Anesthesiologists, they should develop or join a sustainability committee which can cater to issues related to carbon footprint. The comprehensive suggestions by the ASA and WHO for adopting green operating rooms should be followed. All these practices by us can effectively reduce carbon footprint without compromising the level of healthcare provided. The government, it's very important that government should be amenable to suggestions from healthcare providers regarding safe and effective patient-centered health services. There's a large scope for future research in this area with respect to mitigation of climate change and improvement of public health care. So to conclude, perioperative healthcare generation is a considerable amount of hospital waste, which is responsible for generation of carbon footprint. And it has devastating impact on environmental as well as human health. The increasingly challenging concern is providing a quality perioperative care to a patient without generation of significant carbon footprint. So now, last but not the least, carbon footprint cannot be reduced by miracle or magic, though a combination of various available approaches may be useful. Thank you very much for kind attention.